Right now, let's take a look to let's open the focus to see the big picture and what could represent the OCT cornea in the whole picture of the Pentacam for anterior segment surgeons based in refractive surgery, cornea, phakic IOLs, and overall our specialized that could be the simultaneous vision lens, not only in presbyopia correction, but also in cataract. This is our disclosure for this year. It's good for you to know. Well, this is for me the big picture of the equipment of Oculus. We are going to have anterior segment surgery procedure absolutely covered, as you can see here, with the different equipment that we are going to have for the variable involved in the decision criteria. But for me, the key of as I used to say, the magic of Oculus, it's not developing incredible hardware, as they demonstrate that a lot of time, but these two keys, increasing the safety and efficacy of our procedure directly, empowering us to take decision. And overall, this is for me the key, supported by evidence. They develop all this incredible equipment group of research to not only develop hardware, but also give us the power of evidence to increase our diagnostic power. So focusing in the dry eye, as you know, is one of the main concerns in the simultaneous vision lens. When we implant, the main concern of our patient or the dissatisfaction is a dry eye. So we are going to have here different variables involved in the decision criteria. The application for the dry eye of Keratograph, as you can see, is based in the NICMU. It's quite important not to be invasive. The tear meniscus height, also the tear field, analyzing the lipid layer and the dynamic, and also the Biomechanics. So this is going to give us the opportunity with the dry eye report, the GEMVIS, not only to make a follow-up of the dry eye if we treat on them, not only that make the diagnostics, but also the differential diagnostics in between the evaporative and hyposecretor dry eye. So it's excellent option equipment to follow up this possibility. So then what we are going to have the different families of Pentacam, the HR, the AXL, the Wave, and right now the Cornea OCT, and all the variables involved. But let's take a look in what would be the roadmap developing of this equipment. As you know, we began in 2002, a long time ago, so developing the rotation chain flow. Then we had the opportunity of make not only the analyzing directly to the refractive corneal surgery, but also the calculation, the intraocular lens with the AXL. Then we have the Wave Pentacam with the possibility of making the follow-up and diagnostic of the wavefront, refraction, and retroillumination. So select the best patient, select the best intraocular simultaneous vision lens, and also doing the follow-up of possible complaints. And right now we have the possibility of analyzing, as we never have, the cornea with the Cornea OCT. So as you know, the Cornea OCT is linked to the chain flux technology, to the Pentacam HR. So let's take a look for the AXL Wave. Okay, we could have this screen of fast review. You can customize with all the screen that you would like to have, but the possibility of having the objective refraction and the aberrometry, the total eye aberrometry in the night and the night condition, the possibility of having the Stasia screening and different biometric variable. So in the first screen, you could have a big picture of your patient to take a decision based on that, and also the overview map and indices explanation for the patient. All this map is going to be covered with the highest level of evidence in order to improve the power of your power in diagnostic to take decision. And I really think it's the key. They develop incredible work, incredible evidence, separating the data, the parameter in between the DC population of the normal population. And this is the key. They incredibly developed parameter to separate as much as possible these two different populations, normal patient and deceive the patient in order to increase the sensitivity and also the specificity, in fact, with the power or diagnosis of the equipment. We also could have in all Pentacam series, as you can see, more detailed assessment of detection, and also the progression control is quite important. Right now, if we treat with cross-linking, for example, or knowing the follow-up or refractive surgery, know if we are going to have a progression of the tomographic parameter. Also, the possibility of doing evaluation of the corneal transparency and the possible optical quality problem. You could have some complaint in different patients after the surgery, and the possibility of differentiating the problem with the optics of the simultaneous vision lens, that's some problem of transparency also in all Pentacam series. And in all Pentacam series, you have also in the preoperative the way to evaluate the corneal shape, trying to explain the optical quality problems. Also, again, separating the normal population of the disease population. Based on that, we have in all the Pentacam series the Maeda criteria, as you know, to screening the simultaneous vision lens. Maeda give us in 2011, as you can see here, the cutoff tried to identify what could be the cutoff based in the RMS at 4 millimeters, what could be the cutoff to implanting simultaneous vision lens. And the key for him, the key for Maeda, was what could be the cutoff in terms of high order aberration to create a blurry vision like a 0.5 dioptry. So he developed this cutoff, and he tells us in this paper in 2021 that probably above 0.3 microns of high order aberration, you could have this blurry vision, and this could be the cutoff not to implant simultaneous vision lens. Well, this year we published this paper in Journal Refractive Surgery, validating clinically the Maeda criteria, as you are going to see right now. But we discovered some very interesting thing, that the safety guarantees, according to different aberration, would be in the right side, this cutoff for spherical aberration, the coma, and trefoil. But probably the most important is the parameter most important to analyze is the high order aberration, the RMS at 4 millimeters, as the indicator that best could predict the visual performance after the implantation of the lens. And it would be quite important because for Maeda, the cutoff of 0.3 microns would be not to implant the simultaneous vision lens, but we discover that between 0.3 and 0.5 microns would still might be safe, but it's quite infrequently to discover this number in our patient. So take a look at that. You can see the defocus curve, the area under the curve of different defocus curve. And to the right, the correlation, the possible correlation with the high order aberration of 4 millimeters. As you can see, we don't find any correlation according to that. So, well, with very high order aberration, more than 0.5, it would be clear that we are going to achieve less area under the curve or the defocus curve, but we don't find any correlation. So mesopic pupil, for example, the diameter of mesopic pupil, the age, and even the chart luminance, as you know, in research, we need to use 85 candles in comparison with clinical 250. It's more important for the performance of simultaneous vision lens than the high order aberration. Quite important also, understanding the multifocal cornea. It's information you are going to have in all the Pentacam, but specifically for me, it's quite important to see in the Pentacam AXL Wave the possibility of see the retroilluminated images of the simultaneous vision lens. You can automatically calculate with this mass, the centration, also the rotation or possibility of rotation of some toric lens. So you are going to find clearly the explanation for some complaints of your patient in the postoperative. Talking about intraocular lens power calculation, specifically with the AXL and also the Wave, you can see very interesting thing, because if your assistant make for you the calculation, you are going to have some red line detecting out the normal range between eyes and within the eye for preventing clinical errors. So it's very useful. All the information that you are going to need for the calculation, and also the possibility of automatized constant fit. So Demian published last year a very interesting method to create this constant feed. Bonsanti, another very easy to do, but also in Pentacam you can use in a very easy way. We can go another step forward is the combination of Pentacam with Corvis. For me, it would be great in the preparative of laser refractive surgery. And this is all the clinical application that you could have in combination Corvis with Pentacam. So see the safety of the preparative in the screening of laser surgery, the progression of the keratoconus, also the follow-up in the postoperative laser corrected of refractive surgery. Also, to evaluate after cross-linking the progression of the corneal stiffness, and why not the glaucoma assessment, quite important beyond conventional intraocular pressure. Again, the differentiate in the normal and the disease population distribution, as you can see here, this is the typical screen of the TBI. Now we are going to see after in another presentation the new TBI 2.0. You have the CBI here, all the information in the tomographic, and the combination is not a mathematic, but also using artificial intelligence to improving our power in the diagnostic, as you can see here. And right now we have the highest level of evidence published in literature, try to discover the subclinical keratoconus, as you can see, with a 84.4% of sensitivity, 90 of specificity, and a significant power of 0.945 to the new cutoff of 0.5. So let's take a look. It would be interesting to have this information, absolutely. For me, it's quite important. Look at this patient, for example, with a TBI 1.0, with this girl of almost 40 years old, with this low refraction, that we decide with this TBI implanting ICL of 0.58, but with a new TBI 2.0 increase. So this was very helpful for us, this information, to decide the procedure to make in the refractive surgery. Also, in the screening of the preoperative refractive surgery for cornea, we have different preoperative indices and biomechanics intraocular pressure, as you can see here. What is the value according to the normal population? And you also could discover directly if the patient was operated on cornea. The reduction of bias between preoperative and postoperative stage, and quite important, to follow up keratoconus, we are going to have the classification of Belling ABCD. So to manage the progression by biomechanics, not only tomography, it's quite important if you are going to treat with cross-linking, for example. We could also evaluate the stiffness, not only as we had in the first applanation, the SPA1, it means the stiffer cornea at the first applanation, but also with a lower SSI, mean the stiffer cornea along all the stress range. In the Corvis also we have the possibility of skill for patient education to explain this index, and also to screening the anomalous intraocular pressure. As you can see here, with a very high intraocular pressure, but very high also stiffness, we could take apart the possibility of glaucoma, but look at that with this very low intraocular pressure doing the screening of normotensive glaucoma according to the biomechanical properties. So OCULUS technology is developed the next step, as the Professor Alpha tells us, and Demian is going to talk later, with the Pentacam Cornea OCT and the different variables involved in the decision criteria. Take a look, imagine all that we wanted, include the epithelial thickness in our take decision. It would be absolutely great, not only to improve the power of the diagnostic of keratoconus, but also possibility in the future to customize with a very high resolution laser. You have here the two possibility of display mode, the real shape. As you can see, this is the cap after 24 hours for a smile, the actual corneal morphology with lower resolution. And even in the real shape with this smaller resolution, you can see the comparison that we have more better performance with all the equipment of the market. But take a look. This is the key, no? The zoom display is practically a histological view that we are going to have with a very high resolution. Of course, we are going to have a complete visualization of the cornea with a very high resolution, with, of course, this comparison of the morphology. But this is the key to see all the structure, histological structure directly in your screen to evaluate different situations that could have. Take a look of this paper published talking about the possible micro distortion after a smile with a resolution of 1.93 microns in a field of only 3 millimeters, but you could have the possibility of having this exactly the resolution coverage up to 15 millimeters. So this is incredible right now. Also having the epithelial map, as you can see, different possible of clinical cases that Damien is going to show us right now with stromal scar, the possibility of meso, all the structure, the subepithelial corneal degeneration, as you can see here. This formation is under the Bowman, the subepithelial corneal degeneration, epithelial bullar in cicatrization, cornea evolution, the follow-up of corneal ulcer, endothelial corneal precipitate, as you can see, and also the possibility of seeing in a video, as you can see here, the different structure of endothelial and descent breaks in endothelial corneal precipitates. So in conclusion, as we will talk, OCULUS provide the highest evidence-based technology. It's not only hardware. It's the way that we could improve our decision screening based in corneal refractive surgery, phakic intraocular lens, and simultaneous visual lens. Finally, you could have in the Apple Store our application in EOL Evidence. You could find all the literature published of all the simultaneous visual lens. In the way that appears in PubMed, you are going to see the sum up of all the papers here for iPad, iMac, and iPhone, and also to invite you to the next Congress in Copenhagen on the CRS. So thank you very much for your attention.